It's a great pleasure for me, ladies and gentlemen, to introduce Professor Mazen Khairallah, who is a professor of intensive care and infectious disease. He is certified by the American board in other two areas. Now, the first one is internal medicine, and the second one, which I have just learned, is a neuro ITU as well. Professor Khairallah is currently the chair of the intensive care unit in North Dakota. We hosted Professor Khairallah a couple of years ago. In fact, I'm looking back. It was 22nd of August, 2020. It was 6 o'clock in his own time. It was midday in our time. And we talked about anti-inflammatory agents in COVID before things have moved on from then. Professor Khairallah also have a contribution to the World Health Organization in the Middle East, and he worked with them in particularly in Syria. I would regard Professor Khairallah to be a world expert in the area of COVID, and today he will talk about COVID-19 prevention and treatment. I would suggest that we leave the questions towards the end of the presentation. Thank you very much indeed, and the floor of yours, Mazen.
Oh, thank you, Nabil. Thank you for inviting me again to talk in this on this platform. I cannot imagine it's been 2 years, and if we had a discussion in August 2020, that means we only had steroids at that time that were approved in terms of treatment for those severe cases. So I'm going to start by saying first that I do not have any financial or other conflicts of interest to disclose. And the talk will be organized in a way that we start briefly talking about the infodemic that we all live together, and then a brief update on the pandemic before we talk about the variants and the pandemic impact as it is at this point. And then we look at the vaccine efficacy after all those variants have emerged, to conclude with a lengthy discussion about treatment options. And this was actually very discomforting that we had to live the pandemic with an infodemic at the same time. We all have witnessed those different pseudoscience. Let's say we have seen people talking about cow urine, bleach, and cocaine for the treatment. We've seen the bogus therapies, hydroxychloroquine, ivermectin, and then the theories about the virus being byproduct of 5G wireless technology, and the political hoax that has been claimed by remarkable people in the administration, and then the theory of leaked bioweapon. In addition to the vaccine being a microchip that is going to control everyone. I just want to say, with all this in the background, I think we have a higher responsibility. We have to respond to this misrepresentation. It is our professional responsibility. We have to promote accurate, balanced, and responsive public representations. And we all should promote both trust in science and trustworthy science. And this unfortunately impacted personal choices of people in terms of whether they get vaccinated or not. This is from the KFF COVID Vaccine Center, where it's looking at the current situation with the updated COVID-19 booster, which is bivalent. And as of 1st of November, I mean, it may have been actually late September. At that time, there were only 5% of the US population who got the updated booster. But interestingly, only around 32% were willing to take the vaccine. And if you look at different age groups, you will see that the youngers, the more educated people, are less willing to accept the vaccine compared to the elderly people. And not only that, the political affiliation plays a major role. You can see here Republicans being not more than 13% who are willing to either got the updated booster or willing to, compared to Democrats, more than 60% of people. This has led to multiple impacts in terms of how the pandemic has evolved over the past 2-3 years. And we all witnessed those waves. And I'm not going to go into details about those waves. This is the most current as of November 1st that I have here. I updated this slide just 10 days ago. And you can see this is a comparison between or among Germany, United States, United Kingdom, and Canada. And this is just the daily new confirmed cases. If you want to look at this in relation to the population, this is per 100,000. And you can see that Germany had very two new peaks compared to the other countries actually. But I want to call your attention that we are living what we call right now pandemic fatigue. And that led to a drop in testing. People are not getting tested for the COVID, and also in some countries around the world, they started to under-report those cases. In addition, we know that we have a lot of home testings, and those are actually not reported. And in fact, myself, I got tested at home and was positive just a few months ago, and it was not reported. So there are many cases in the community and are mild cases. This is what's happening in your area in England and Wales, very similar to what's been witnessed around the world. And this is the current situation in the United States as of November 1st. We had a total of 20,000, around 20,000 hospitalization. The vaccine updated booster rate was around 7%, and weekly deaths were around 2,500. The weekly cases were around 260 to 265,000 cases. And of course, the excess death has improved remarkably compared to the previous waves that we witnessed. And you can see that we're still witnessing higher rate of death compared to the expected rate of deaths. And this is a similar situation in England and Wales. So now the problem is that with this virus is a sloppy virus. When it replicates, it doesn't do a good job. And there are multiple reasons actually for prolonged replication or prolonged survival in the host. Of course, the lack of global containment played major role in sustaining the virus replication. But the most important factor that plays a role in terms of having more variants is having the virus replicated in the same host with prolonged infection. So prolonged replication is noticed in immunocompromised patients. And of course, we have animal host and animal reservoirs. Co-infection recombinance effects could have played a role in making this virus replicate more and then translocate and coming up with those variants. And if you take a look on what happened over the past 2 years, you would see here the different variants that we have lived through. And you can see the bar moving to the right side on the left here, where we've seen all those. This is the Delta virus now, and then we start to see the Omicron and different clades of the Omicron. And now at this point, we're in this area here. If you take a look on it in a static way, you will see how in 2020 we started with the original virus, and then it evolved into so many variants that it's very difficult to keep track of. And we barely know the names of the main ones, actually. The Omicron started here. You can see there are different clades of the Omicron. And now we're seeing the most recent one is the 22F Omicron that is actually started in the Far East. You can see the red color here. And this is the distribution of different variants around the world. And in the United States, if you compare just in a matter of weeks, you can see this is the first week of October, and take a look on the black color here. You can see how it's actually doubled almost every week. And this is now it's increasing in the spread, the BQ11. And the other one is the green color. You can see the BQ1 is increasing over the past just 4 or 5 weeks. So those are the new variants that are circulating or actually increasing in circulation. Still, the predominant one is BA5, but it's shrinking as you see here, and it's taken over by other variants. That has a lot of implications as we see in terms of the therapies. But this is the distribution of the different variants around in the United States in different states. So in terms of the variants, I would conclude that the RNA viruses are very sloppy replicators, and they are much more prone to random mutations. Omicron is less virulent, luckily, but has a higher infectivity rate. And we will continue to see new variants as the pandemic is not contained. And the most common ones right now that we have, or the ones that are increasing in terms of rate in the United States, are the BQ1 and BQ11. So what about the infection fatality rate? And the comparison with influenza makes a lot of sense, actually. Influenza is seasonal infection, and it's monitored year after year, and the fatality rate for it is close to 0.1%. Now, if you take a look here on the fatality rate in comparison, and this is in England, if you compare it with the COVID, you can see early on in July 2020, it was much more lethal compared to influenza, 20 to 30 times higher. But as we observed the pandemic and we started getting those vulnerable group vaccinated, we started seeing that the infection fatality rate is dropping. And then when we gave the boosters to those people also, you can see further drop in the IFR. Now, with the newer variant, the Omicron, which is less virulent, we noticed that the infection fatality rate is very close to the influenza. However, since the attack rate is higher for COVID, then the impact is going to be much more. So the attack rate for influenza in a very good season is not more than 20%. Compared to COVID is higher than 70%. It may reach 90% also. So the impact out of the COVID is going to be at least 10 times of influenza. And this is seen, this is the data from your area again, England and Wales. And you can see now, despite all the efforts, the deaths reported in the area here are equal to, this is the red line is the COVID-19, and the green line is all other deaths due to influenza and other pneumonias. So you can see COVID is still playing major role in terms of the impact in the community with high mortality rate. Now, how can we explain the lower rate of hospitalizations and deaths compared to the start of pandemic? I alluded to that. Number one, less virulent variant. Number two, we have a higher wall of immunity with prior infection immunity and vaccine immunity, and that's what we call right now hybrid immunity. And then we have more effective treatment for those patients at higher risk of progression into severe disease. The pandemic impact, I think, is underestimated. As of today, there's 6.6 million deaths around the world, but I think this is underestimated. I think the true excess death is probably around 13 to 16 million so far, and driven mainly by India, and you know that the reporting was not that great in India. As I mentioned, the infection fatality rate is approaching the influenza fatality rate, but it has a higher impact because of the higher attack rate. And of course, we had other secondary health impact of the pandemic, which is represented by the disruption of access to healthcare in different areas, in addition to vaccination rate for other illnesses has dropped also. And that takes me to talk about the vaccine. And as of last month, this is the total number of vaccines that were administered in the US with the different vaccines that we have available here, Pfizer, Moderna mainly. And this is the distribution of vaccination rate in different states. You can see the democratic states have a higher vaccination rate. This is the rate of completed primary series. And this is the rate of updated bivalent booster dose. You can see that it is not more than around 7 to 10% in most of the states. This is very interesting. This is in your area. This is in England. I thought it would be worth to spend a minute or two on this to see how things have evolved. And let me explain this to you, because it's looking at on the y-axis here, you will see different age groups, and the time on the x-axis. Now the color in this slide here, we're looking at cases that were reported, and the denser the color is, the higher the cases. You can see we start from the yellow all the way to the dark pink. Now at the start of the pandemic, you will see that the younger age groups were not that much affected here. And this is the first wave. You can see the major or the highest number of cases were among those elderly, the most vulnerable to infection. Now, with the second wave, where we had the Delta virus, you can see that infection rate has actually affected all age groups, and including pediatrics. You can see here even 0 to 4 had a high number of cases being reported. Then we had some improvement, and we'll see how did that happen. The rate came down a bit before we got another splash or blast of infection, higher infection rate in the community by the Omicron variants and others. Now, if you take a look on deaths, you will see they were mainly concentrated in the higher age groups. However, if you take a look here, you can see that even the younger population age groups of 40s and higher had a very high, relatively speaking, very high mortality rate, and then came down here before when we had the Omicron here, it increased once again. If you put this actually, if you plot it against the vaccine uptake rate, this is the first dose of the vaccine. You can see that it is started with the in the middle of the Delta wave, and then this is the second second dose, and this is the booster dose where we really had a good immunity in the community to be able to get a lower infection rate and lower death rate in the community among those cases. Now, a lot of people would say, well, I've heard that the natural immunity from infection is better than the vaccine immunity. Why should I be vaccinated? Well, the answer is probably more complicated than just simply say, if I had an infection in the past, why should I get vaccinated? Well, this is, there are so many studies actually, but I just wanted to bring this one. This is from Qatar. And this is looking at the effectiveness rate. And you can see here in the blue color, this is previous infection. This is if somebody infected previously, would have still effectiveness of preventing further infection in not more than 65% of the cases. But this is after 4 to 6 months. Now it goes down slightly, 62.5%, down to 48% after almost a year. In more than 12 months, it is still around 50%. Now compare this to effectiveness of the vaccine. After the first dose, this is second dose actually, after 14 to 13 months, it is 40% only. And in 4 to 6 months, it goes down to 14%, and then it's very low after 6 months. After giving the third dose, it is we don't have data after 1 month, but it's 58% down to 44%. So what we understand from this, probably getting infected is going to give you better immunity compared to getting the vaccine. So why are we vaccinating people? Well, the answer is in the same study. Take a look here. Now, if we, in the previous slide, we talked about reinfection. What about hospitalization and death? Well, with prior infection, it is effective in preventing hospitalization and death in 73%. If we get 2 doses, 76%, very similar. Well, if we get 2 doses and prior infection, it is up to 98%. And the 3 doses alone has similar effectiveness. If you get 3 doses and prior infection, it's almost 100% in preventing hospitalization and death. And this is very remarkable actually. This is without any question tells you that, well, I would rather be vaccinated. If I had an infection, well, that's extra immunity, and that's what we call the hybrid immunity. And this is complicated. Again, this is from Canada, but it gives you the fatality rate with Omicron. And let's just concentrate on the age group 18 to 29. This is the age group that is actually not accepting vaccination as compared to older ages. So for 1,153 patients who are infected with Omicron, it would be 1 death. And that's if they received less than 2 doses, meaning that they are not vaccinated. Now take a look here. With 2 doses only, after 6 months, we can cut this into half. It will be only one death out of 2,200 infected patients. And if we get 3 doses, we cut this by 90%. One death for 10,000 almost. Similarly, hospitalization rate is cut at the same rate also. One hospitalization for 256. If we get 2 doses, one for 596, and 3 doses, one hospitalization for 1,000. Look at the impact and the effectiveness of the vaccine in terms of not only hospitalization, but also deaths. And we have to know that this is very dynamic. It's very difficult to keep track of what's happening and difficult to assess the efficacy of the vaccines across all different variants and over time. And there are not enough studies actually. We would not be able to study every variant and see how the vaccine is actually working in the community at a larger scale. However, we can see this in smaller experiments and studies. And if you go to Open Data website, they have a very nice graphs that you can actually change dynamically to look at the different efficacy. And here, everything, this is a one line, everything to the right, meaning that it's less active, everything to the left is no reduction. And you can see the effect of different vaccines. You can select which variant that you have, and you can see the efficacy of the vaccine towards that variant. And as I said, it is very dynamic, it's changing. So in terms of vaccines, we have significant reduction in the hospitalization and death rate as an effect of the vaccine. Vaccine hesitancy is still a problem. There's disparity between vaccine and vaccination. And so far, the updated vaccine rate, uptake rate, is not more than 7 to 8% in the United States. And just for your information, US has been the largest donor of vaccine to needy countries. And this will take us to treatment. And in terms of treatment, it's probably there are thousands of studies so far. And we've noticed this, we lived this. It was very difficult to keep ourselves updated with this many number of studies coming out. However, I think we benefit a lot from different style of doing research with the adaptive platform of those studies. And the major ones that played a role in shaping the way we are treating our patients with COVID-19 are coming from mainly England and United Kingdom. I mean, the principles study, the recovery trial, and then the WHO with the solidarity trial. And from the US, we had the active 1 to 6 and active associated trials, in addition to the international trial of the REMAP CAP. So I'm going to look at those studies, how they benefited us in terms of the knowledge that we acquired throughout the past 2 years. Starting with the recovery trial, which is the most remarkable trial, in my opinion, that we have known in COVID. And the trial actually tested multiple agents. You can see the trial is conducted in more than 199 different sites, had more than 50,000 COVID patients in the trial, and looked at different agents compared to usual care. And as this trial is actually moving forward, once we find out that there's an agent that is helpful, it will be added to the usual care. Like what you see here, the initial agent in June 2020, hydroxychloroquine dropped out of use, and we stopped using hydroxychloroquine. And dexamethasone was added to the usual care of patients by June 2020. Found out that loperamide, ritonavir is not effective, azithromycin is not effective, and this is in hospitalized patients. Azithromycin and convalescent plasma, and then tocilizumab was effective, and was added to the usual care, of course, in certain population of those severe cases. Colchicine was found not to be effective. Aspirin, the same thing. Monoclonal antibody, but of course things are variable now because of the variants that we have. But the first one was added to our treatment plan in terms of prevention of progression into severe cases by June 2021, which was the Regeneron. It also tested the baricitinib as of March 2020 and was added to the usual care. We're still waiting for results of other agents that have been tested in the same trial. The second trial is the principal trial, which is also from United Kingdom, and it's concentrated on COVID cases in the community. And the trial found out that azithromycin adds no benefit. Similarly, doxycycline is negative. Inhaled budesonide was a positive study, but it did not make it to the guidelines by at least NIH, but there is data to support using inhaled budesonide in the community. Colchicine was negative, and we're still waiting on other agents. The United States had the active trials, and as I said, there are actually multiple trials. Goes from 1 to 6, and then they added the active associated trials into the same group of trials. Tested different categories and agents, and so far we have few that are positive out of this trial that we're going to delineate in the next few slides. The ACT study revealed that remdesivir was the first agent to be effective against the virus and utilized in multiple or recommended in multiple guidelines, followed by baricitinib, and we found out that interferon beta is not effective. The baricitinib with remdesivir was tested against dexamethasone and remdesivir and found similar efficacy. The Solidarity trial from WHO did not find the same results for remdesivir and was negative for the other agents that were tested, including hydroxychloroquine, lopinavir, ritonavir, interferon, and we're still waiting on results for other agents. And should also mention the REMAP-CAP, that is international collaboration of adaptive platform trial in community-acquired pneumonia that gave us a lot of information too. Now, when it comes to treatment, we should decide about 4 different agents or categories. First, we should say, should we give antiviral or not? And the antiviral that we have right now, remdesivir and Paxlovid mainly. And then do we have any role for monoclonal antibodies in case we don't have the antivirals? And then should we anticoagulate our patient or not? And then the last question would be, should we give anti-inflammatory agent or not? Mainly dexamethasone, baricitinib, or tocilizumab. Now, I'm going to combine the monoclonal antibodies with antivirals. It's essentially monoclonal antibodies are antivirals, but work in different mechanisms. And I'm going to look at these agents in terms of the progress of the cases. Let's start from the left here. We have a group of patients who are not hospitalized and have no risk of progression into severe disease. And then we have others who are still not hospitalized but have high risk of progression towards severe disease. And then we have patients who are hospitalized and do not have or did not require yet oxygen supplementation. And then we have patients who are hospitalized and required oxygen. And not only that, the bar here indicates that the oxygen requirement is increasing. And then we get to the level where they are requiring either high flow nasal cannula or non-invasive ventilation. And if they get worse, they would require mechanical ventilation or ECMO. If they get better, they get discharged home. Now you can see the second bar here is virus replication. The highest rate of replication would start early in the disease, and then as the disease is progressing, we have less replication. We may have some minimal replication by the end. Of course, in patients who are continue to be sicker, they may have a longer replication rate compared to patients who recover. At the same time, we have SARS-CoV-2 mediated immune response. This immune response is actually started very low here, and as we go to the right side, there's the highest immune response that you can see in those patients. So in other words, we need to have agents that are targeted against the virus in early stages of the infection. As we move to the right side, and it is a spectrum, there is no way I can know exactly when the patient is going to transform from viral replication towards immune response. It's a combined. The more we go to the right side, the more immune response we're going to have and less replication. And of course, if we have a higher immune response, we're going to use agents that are anti-inflammatory agents. I'm going to go back to those agents at the end of discussing the different treatment options, but also I want you to know that the efficacy of those medications may vary. And if you go to the same website, the Open Data website, you can see the efficacy of the different monoclonal antibodies. If it is to the right of the one line here, the efficacy is much less. And this is actually, we're looking at the efficacy of different agents against the BA.4/5. And you can see most of the agents that we have right now, except for the bebtelovimab, are actually not effective. And things may change from week to another. And the Paxlovid is actually the medication that is preferred in those patients with higher risk to progress into severe disease, as it's shown in the study that was done, and I think we had the results last year, and it showed that there's a remarkable decrease in the rate of progression in those patients who received Paxlovid, which is a combination of two antiviral agents. And you can see here the dissociation in terms of the hospitalization for those patients, the progression into, it's a composite outcome of hospitalization and death from the COVID-19. You can see the separation between patients who received Paxlovid compared to placebo, and the efficacy of this medication in preventing progression into severe disease, hospitalization and death was close to 90%. So if it is available and the patient is at higher risk, it would be the option of choice for your patients who are at risk of severe disease. And this is tested also in the Omicron surge, and you can see here still effective, especially in patients who are 65 years or older. Remdesivir has been also tested in those patients who have higher risk of progression towards severe disease, and it showed that it is also associated with remarkable decrease, close to 90% decrease in rate of progression. If those patients were sick enough to get into the hospital, and the initial study, the ACT-1 study, showed efficacy of remdesivir in terms of faster recovery. However, with the analysis of the data, we found that mortality was observed to be much less in patients who received remdesivir compared to placebo if they were on low oxygen therapy. Compared to if they are on higher oxygen therapy, the efficacy is not that great. So this is a subgroup of patients who really can benefit. And again, this is early in the course of the disease. Those patients who are progressing, they have higher replication, and then targeting this virus with antiviral agent would actually make a difference. Once they become more inflammatory, once they become requiring more oxygen, at that time antiviral therapy may not benefit that much. And this is actually proven in even the Solidarity study. When they looked, the Solidarity study was a negative study for remdesivir. However, when they looked at those patients who required oxygen but not ventilated, and combine the data with other available studies, you can see the clear benefit of remdesivir in this graph here. Again, I want to keep reminding you that things may change, and going back to the open data the site that I have here for you, and have the QR for you if you're interested to go directly to the site and look at the efficacy of different antiviral agents that are available against different variants that we have in the community. The second thing is anticoagulation. Should we anticoagulate those patients or not? Well, based on the study that was published in 2001, and this is a combination of the investigators of three major platform studies, the heparin in non-critically care patient was effective in reducing the mortality, as well as increasing the organ support free days. So it was a positive study. However, in patients who are critically ill, the study was negative. It did not make a difference in terms of the primary outcome, whether we're looking at the mortality or the organ support in critically ill patients. Those patients who received anticoagulation did not have benefit of it, and we did not use full anticoagulation unless we prove that there is a thromboembolic event occurred and the patient is indicated for anticoagulation. This is also confirmed in the Hep COVID trial, and it had two arms, one for outpatient, one for moderate cases and one for ICU patients. And it was positive in the hospitalized patients. However, in the ICU was negative. So we had actually good confidence that we should not use anticoagulation if the patient is make it to our ICU till a few days ago. And this is as of November, I think 2nd or 3rd, the COVID PACT study is positive. Those patients who were in the ICU had actually higher win ratio, not ratio of 1.95. They benefited from full anticoagulation in the ICU. However, mortality rate was not different. Those patients had a lower rate of whether it's venous or arterial thrombosis event in the ICU. Of course, the guidelines for NIH still recommends against using anticoagulation, but things may change in the near future, and that's what I mentioned, that things are dynamic. The last thing I want to mention is the anti-inflammatory agents. And this is started with the dexamethasone. I'm not going to go into details, but those patients on oxygen therapy benefited from anti-inflammatory agents, meaning the dexamethasone. And when you combine all the studies together, you can see how effective adding anti-inflammatory agents to the treatment of severe cases. And this is for tocilizumab. So tocilizumab was actually better in improving outcome in those patients who had higher inflammation compared to others. And even the data is more robust for tocilizumab than sarilumab. So it is our first choice to give tocilizumab compared to sarilumab, unless it is not available in your area. And then the ACT-2 trial for the baricitinib showed that the anti-inflammatory agent baricitinib is actually effective in those patients who require high flow oxygen or require non-invasive mechanical ventilation. But if they were on lower amount of oxygen, you can see here there is no good difference in terms of the mean time to recovery. This is mean time to recovery in those patients who are requiring high flow oxygen or non-invasive mechanical ventilation. So let's plot those different type of therapies to the stage of the disease. Of course, if you are dealing with a patient who has no risk factors to progress into severe disease and not hospitalized, then there is no need for treatment. Of course, we recommend that those patients can get vaccinated if they were not vaccinated before. However, if the patient is hospitalized, if the patient is not hospitalized and has risk factor to progress into severe disease, then the first choice is to give the patient Paxlovid if it is available. If it is not available, we can look at what's the current situation of our monoclonal antibodies. Most of the current ones are actually lacking any efficacy against the circulating variants of the virus. So we need to look at the studies, we need to look at newer agents and see if they are effective against the circulating virus before we decide about giving the medication or not. The earlier we start with the agent, here you can see the greenish on the left side, yellowish on the right. So the earlier we start with the agent, the better the results. This agent will not help much if you delay the start of Paxlovid more than 5 days. So we recommend to give it as soon as possible to those patients who are at high risk of progression into severe disease. Now, as I mentioned, if Paxlovid is not available, you may consider giving remdesivir to those patients, and the infusion rate is only for 3 days when it is outpatient. Now, if the patient is hospitalized, but he does not require oxygen, there is no need for any anti-inflammatory agents. The recommendation right now is to give remdesivir to those patients. And no recommendations to give full dose heparin, only prophylactic dose heparin. If the patient requires oxygen at this time, we start thinking about anti-inflammatory agents. We can start the patient on dexamethasone plus one of the other two agents, the JAK inhibitors, baricitinib, or if we see that the patient is rapidly progressing in terms of the oxygen requirement, needing high flow nasal cannula or non-invasive mechanical ventilation, at that time you can give tocilizumab for the patient. I would choose only one agent, whether it's baricitinib or tocilizumab, and we'll continue giving the dexamethasone throughout. Now, for those patients on mechanical ventilation or ECMO, there is no benefit of baricitinib. At that time, you would just look at giving those patients tocilizumab. Just bear in mind that the half-life for tocilizumab is very prolonged. So if you give one dose of tocilizumab, you're committing the patient to all the complications of tocilizumab for longer, meaning the opportunistic infections, compared to baricitinib that has shorter half-life, and then you can stop it at any time and eliminate the immune modulating effect of the medication. As of today, the NIH recommends using therapeutic full dose heparin if there is no contraindication in those patients hospitalized in the hospital, but not in the ICU. So we give it only to those patients who are in the hospital. And of course, do not forget supportive and symptomatic management throughout, even after discharge from the hospital, especially now with the post-COVID symptoms and syndromes. With this, I would like to also mention that one of the things that we experienced are the living systematic reviews and network meta-analysis, a very good tool that is available to you. As I said, so many, more than 500 different trials looking at different outcome measures, and you can look at this website and look at the network meta-analysis and how they came up with the recommendations. Also, I want to say that COVID taught us that probably looking at personalized medicine is the direction for the near future. COVID gave us more homogeneous group of patients where we have seen that anti-inflammatory agents worked against those patients, talking mainly about ARDS patients compared to ARDS prior to COVID, where steroids did not show benefit. Probably we're going to select certain indicators that will target personalized therapy in a better way. As of now, we have inflammatory agents that can provide information about choice of therapy. We have D-dimers level can give direction towards anticoagulation, and also we have some indication that some markers like procalcitonin that can actually put the patient at risk of secondary infection and prevent from using some of those agents that we have. And measuring the interleukin 6 can actually track disease progress. In summary, I'd like to say that we have noticed significant drop in COVID cases, mainly because of the pandemic has changed. However, we need not to forget that we have pandemic fatigue that leads to a drop in testing. We are under-reporting COVID tests in certain countries, and we're using home rapid testing at home. The pandemic impact is actually remarkable. The true excess death probably far higher than the actual death that we have reported. The infection fatality rate is approaching the influenza fatality rate, but the impact is higher due to higher attack rate. And the pandemic has secondary direct healthcare impact, mainly because of disruption of access to care and vaccination. Variants are going to continue with us. Those viruses are sloppy and they're going to mutate, and we're going to encounter new ones. Vaccines going to be continue to be a challenge in terms of the uptake rate. However, we have enough evidence to say that the vaccines have significantly reduced risk of hospitalization and death. And in terms of treatment, data is dynamic and evolving. Only a small number of medications were approved among so many that been tested. And in terms of the monoclonal antibodies, probably we lost the effect of almost all currently available ones, and we're looking at newer ones that are going to be available in the market very soon. Effective medications, we have effective medications for prevention of progression in high-risk groups such as Paxlovid. With this, I would like to end my presentation, and thank you very much.
Thank you very much indeed, Mazen, for this comprehensive and very clear presentation. Can I just ask anyone who would like to ask question, either raise hands or just unmute and ask the question?
Hello?
Jonathan.
Yeah. Well, it's a fascinating talk, and thank you for a very sort of comprehensive review of all the various options and how they fared with the testing. And it's obviously been a fantastic kind of effort by the scientific community to get all this work done sort of in real time while we're battling with the pandemic. Where do you see the next step? What do you feel where things should go in the future of this? Because it seems like once people get really ill, the treatments get to be kind of less and less effective. And are there other things on the horizon which could make a big difference in the very ill patients?
Yeah, thank you very much. Great question, actually. So the focus is on prevention in those patients who acquire the infection, prevention of progression into severe disease. However, once they progressed and we have the patient advance into the period where there's huge inflammatory reaction, the options available right now are limited. We have new medication in the horizon that's been in stage 2, sabiluzabin, and the medication is only at stage 2A and B. it has a good efficacy in those patients who progressed into severe disease. It's oral medication. The efficacy is 30 to 50% reduction in mortality so far. It is similar to colchicine medication, but higher efficacy, so it works on the tubules inside the cells, where it's been presented to the FDA right now, and discussion is undergoing at this point for that medication. Of course, other trials for other medications still early on, and it looks like this medication is the most promising one at this point.
That sounds rather encouraging. That one, because it's really hitting the worst difficult cases, or potentially. Thank you.
Paul and Lois, if you could unmute, please. Yeah, Paul, Lois. We can't hear Paul. Sorry, Paul, we can't hear you. Terry, you're next. If you could unmute and ask. Terry Campbell. Terry or Paul, just unmute and ask. I can see hand. Bristol Midkai, you are
Sorry. Sorry. I'm hopefully yes, you can hear me now. Good. One thing that I was struck by with all of this discussion is the problem that the organism is changing rapidly, and the problem of actually trying to get results from therapies which in real time that will actually be relevant to the current variant of what's going on. And it feels at the moment like we're playing catch up, which also means that the sort of anti-therapeutic brigade, the conspirators, or whatever you want to call them, can certainly point to the evidence of, you may claim all this evidence for therapy, but it's not actually there for what is the one that's out here now. How do you think we cope with that?
Well, it's yeah, it's very difficult situation, and we need to differentiate between agents that are antiviral, and those are the ones that are going to have difficulties in terms of catching up with the most current variant, compared to immunomodulating agents and anti-inflammatory agents that will be dealing with the consequences of the infection, no matter what is the variant. So number one, we have noticed so much advancement in understanding the immunomodulating agents, and this is a benefit for us to understand how those agents that have been actually with hundreds of trials in the past in sepsis and ARDS did not actually show benefits, and now with COVID we started seeing benefits out of those anti or immune modulating agents, talking about the steroids and the tocilizumab baricitinib. Now it is more difficult when it comes to an RNA virus that is replicating and changing. You're 100% right that an agent, and that's why I presented actually those, I gave that website that is given this up to date like this one here. So those are the antiviral agents that we have, and what is the current efficacy of that agent against this variant. What was working last month may not be working this month. And that's why the emphasis would be more towards vaccination. If we really need to contain this pandemic in a better way, which doesn't look like it's going to be the case, I think it's going to be like influenza. We're going to have some agents, but the main therapy, the main preventive tool is vaccination. And whatever therapy we have today may not be effective tomorrow. And we have to live with this, unfortunately. And well, this is actually the beauty of medicine, that things are changing and we have to keep updating ourselves and understanding. But think about the community, actually, with all this misinformation in the community, this variability in terms of efficacy of agents and vaccine is not helping us in promoting our scientific evidence in the community. Go ahead.
Louis and Paul, you can unmute yourself. I'm sorry, I don't think Peter needs to unmute you. You can do that.
Hello?
Okay. Sorry, Jonathan, Louis, and Paul has been.
Oh, yes, okay, I'll find.
Are you able to speak? We can't hear you. Okay, Charles. We can't hear you, Charles, for some reason.
This is bizarre because you're not unmuted by me. So you are unmuted by me. So we should be able to hear you. Charles, you've unmuted yourself again. Let's try again.
Yeah, sorry, Charles. You can write your question if you want, and I'll ask Mazen the question if that helps. Mazen, there is a question from Dr. Blackwell saying, is it the virus and the variant that difference, or is the immunity between people are the difference? I don't know if I phrased your questions correctly, Monica.
Well, yeah, I see the question. I think it's very important question. However, I think the way we react against the virus is different from one person to another. And that's why we really need to understand each individual's response to the virus. And this is how we decide whether this patient would need immunomodulating agent or not. And that's what I meant by personalized medicine, is the effect of the virus on the host is different from one patient to another.
Jonathan, you have another question?
Well, I forgive a rather speculative question. Can you hear me okay?
Yeah.
It's one of the things that's very remarkable about the data you were showing was not only how the new variants are cropping up, but how the old variants seem to be dying out. And a solution that is just kind of a bit wacky, but it occurred to me that it would also solve the problem of the failure to take up vaccines, was to develop a new developed variant, which is even more infectious than any of the previous ones, and is absolutely unlikely to cause any serious illness. And that then would run rampantly throughout, hopefully push all the other variants out of sight and provide sort of vaccination for all the people who won't be vaccinated by them catching this harmless variant. So if we could develop such a variant with high infectivity, even higher infectivity than the Omicron, and even lower risk of serious illness, then it would actually solve the disease problem, including the people who weren't being vaccinated.
So almost like taking the live polio vaccine.
Well, not taking it, but making it so infectious that if you don't take it, you'll get it.
Which then cross-infected people around you. Yes.
Yeah.
And this is the principle of the herd immunity. So in this way, you can infect, as you know, it's I think we got lucky that the Omicron was not that virulent compared to the previous one. So, and it was more infectious. The spread is higher. So we infected people much faster, and they built immunity. And on top of that, we had the vaccination rate, vaccine available, and the uptake improved. If we were relying only on the vaccine, and with the uptake rate of around 50 to 60%, we would not have contained the pandemic this way. I think we're in a much better situation today, not because only the vaccine, but also because the virulence and the spread of the infection help us in building this natural immunity in those patients, or the hybrid immunity that we call, and help us to have more patients or more people who are ready to fight the virus when it gets into them.
But do you think the concept of actually engineering a new virus which has higher infectivity but lower in damage caused would then allow us to basically vaccinate the non-vaccinated people by making it so easily caught that they'll catch it whether they like it or not?
Well, this is a nice theory. I don't know how applicable is this. How can you design a virus that you are guaranteeing that if it is spread in the community? Well, that goes to the initial theory that the virus itself is actually a bioweapon. But there is ability to design a virus. I'm not sure if I'm not the person who can answer that question. Actually, I'm not a virologist. But it is, in theory, it's nice to have a virus that circulates and infect people, but does not kill them. I think this is what we need to concentrate on. This is the concept of the vaccine. We have effective vaccines. Let's just promote towards higher rate of uptake of vaccines, because it provides good immunity, and the virus is around us. It's still infecting people, and the attack rate is high still. So I think we're going to get and we're getting into this same outcome with better vaccine, better uptake of the vaccine, and improved virulence of the virus.
Sorry, Paul and Lois, your hands are still up and you are unmuted. Are you able to ask the question?
They put one in the chat.
No, they haven't.
Which is that point that vaccination pushes variants, and so possibly the most vulnerable should be vaccinated, and they should quarantine for 2 weeks after vaccination. I suppose the question is, what is the evidence that there's greater increase in variants in countries which have higher rates of vaccination?
I'm not sure if I can answer that question. Anybody has any experience or knowledge in answering?
I don't think it is. I don't think it is I don't think it is higher in areas that vaccination is high. I think one of the most disappointing things with the vaccine is that it has shorter duration, and it is a lot weaker than we thought. And mainly because the technology currently is directing the vaccine towards the spikes. And there are now thinking that a newer type of vaccines, which will target the envelope and the RNA, as well as the spike, will be more powerful and more transferable between variants. So that is actually a kind of the new thinking of the new technologies, because to develop a new vaccine when every new variant comes in is less efficient and more costly than to develop more powerful vaccine like the polio vaccine. Monica, I think your hands are up, but you are not muted.
Hi, yeah, can you hear me? Yeah,
yes.
I just wanted to say how nice it is to meet, so to speak, Professor Kerala again, because I remember your last talk. And I wanted to ask about the wider response, because I remember particularly you saying that in your area there are 2 hospitals, and you immediately made one a hot hospital and one a cold hospital. And here in Bristol we have 2 hospitals, and we absolutely failed to do that, and we failed to make any formal plans. And I think part of the poor UK response has been our inability to make plans. But what I wanted to say was that this infection, this pandemic, has really thrown into sharp relief the whole societal response to illness and the trade-offs. And I was wondering if you had any thoughts about the trade-offs that have been made, because I'm a GP, a family practitioner, and I've always seen right from the beginning much higher problems with mental health, with unexpected out-of-hospital deaths, with disease progression of late presentations of cancer, much worsening cardiac disease and diabetic disease. And I'm left asking, is it worth it?
Well, yeah, unfortunately, that's what we all experienced. We had a surge of cases after the initial COVID wave, where patients were delayed in terms of taking the care that is required. Cancers that were not diagnosed. Lots of women did not get their mammograph done actually on time. Vaccinations were not given in timely fashion to kids, and resulted into higher rate of hospitalization of different conditions. And it should have been a balance. I think the healthcare system is not prepared to deal with pandemics like this, and probably we did not see the full expected impact also of the pandemic as it was thought. If it was worse than this, it could have been actually disastrous in terms of what can happen with the ability of the healthcare system to respond. I think we need to learn from this, how we can elevate our healthcare system in a way that can deal with situations like the pandemics or any other natural disasters, or maybe not natural also. At the same time, not disrupting the healthcare system as it is in normal situations. We should not have a healthcare system that's only designed for stable situation. I think we have to have the ability to respond. Now, if you see that there are benefits of the pandemic, the benefits that we were able to probably finish trials that before that took years before we're able to get something out of the trial. Now we have those adaptive platforms. We have the mRNA vaccines also that can be modified easily. So I think what we need to strengthen our situations and our healthcare systems to avoid any other shortcomings for in the future of any pandemic or any disaster that can happen in a similar way.
There is a comment from Paul Goddard that there is a now vaccine called Sorensen and Daglish vaccine, and we have been advised to look it up. And that is probably a new vaccine, which is thought to be better than available vaccines. In fact, I'm looking that up now, but probably I'll comment later on if that's okay. And now, I don't know, there were hands. Tom Fruin or Janice, your hands are up. Would you like to ask and unmute?
I should say that I did not have any knowledge about that vaccine, and I will look it up too.
Yes, I mean, I'm just looking up the paper, which is a research article in the Cambridge University Press. It's just, in fact, I looked it up and I will look it up more carefully. I just wanted to make one comment about post-COVID, Mazen, because this has been really an area of interest of ours for some time now after the pandemic. And now people do divide post-COVID according to the COVID itself. And there are three groups of people. The first group is those who had COVID and needed intensive care, and their post-COVID tend to be respiratory and post-intensive care symptoms. The second group are those who have COVID and have COVID and pneumonia, but not intensive care. Interestingly, this group only have respiratory symptoms, breathlessness and cough. Now, the third group are the commonest, are the most difficult, are those group who did not have pneumonia, did not need intensive care. They have ordinary COVID, but they end up with severe symptoms of breathlessness and cognitive impairment. Now, we do have a scheme, so-called the post-COVID clinic, but the clinic is fading away because it is not easily populated by physiotherapists, psychologists, and other staff. And now we tend to refer the patient individually to the discipline that the patient has the symptoms of. There are large trials looking into risk factors for post-COVID, and these trials have shown different risk factors, but most trials have shown that female gender, people who have high body mass index, and people who have comorbid conditions such as cardiac condition are those who have the highest risk of post-COVID. There are now no designed treatment as yet for specific for post-COVID, and we repurpose the medications we have to treat the symptoms.
Could I make a comment on that, Nabil?
Of course, yeah.
I've seen several people in my cardiology clinic with supposedly post-COVID symptoms. And it's interesting, first, that they quite often have mild T-wave changes on their ECG, suggesting that they suffered a degree of myocarditis.
Yes.
But echocardiograms did not show reduced LV function. So this is only just anecdotal, really, because the numbers aren't great. But interestingly, they have all the same characteristics as people with post-viral syndrome have had with other viruses, and I've seen those all my professional life.
Mm-hmm.
They seem to be sort of general symptoms of just feeling unwell, unmotivated, and fatigued.
Mm.
And, I think there's a sort of a neurological and psychological element in that, which is that they were very worried about surviving or worried about having a bad effect. And so the transient symptoms, the transient post-viral symptoms then become prolonged because they then are expecting or they look out for the same symptoms and feel that the problem hasn't gone away. Mm. And what I've done in the few cases I've seen have been to sort of get them to embark on a progressive exercise program, and so far with no problems and with good results. So it could be that it's just a post-viral fatigue syndrome, which requires active rehabilitation rather than necessarily any specific COVID-related pathology.
Totally agree. Yeah. I'm interested, Mazen, of looking into the anticoagulation because this is an area which we really, in fact, wrestled with throughout the pandemic until now. Mm-hmm. And some people say that people with continuous breathlessness look at what Jonathan says, whether there is any subtle myocarditis or if they have microangiitis, which cannot be detected by CT pulmonary angiogram, but can be detected by VQ scan and by more modalities of investigations that look into the small vessels in the lungs. Currently, we give anticoagulation to people who have D-dimer over 1,000, breathlessness, and desaturation on exertion. These are kind of the three conditions we give anticoagulation. But there is now a big shout to giving people aspirin to this particular group because it is microangiitis. I don't know if you have any thoughts about that.
Well, the study that I just put out, which was released early November, is 2x2 factorial design, looking at number 1, the anticoagulation, and number 2, antiplatelet effect of the Lavix. But this is in hospitalized patients, and they found out the Lavix had no role in improving outcome. And there are multiple other studies also looking at the aspirin, whether it's outpatient or inpatient, that have shown so far no positive effect. So I cannot make a recommendation for any antiplatelet agent yet without having stronger evidence to support its use. Now, using anticoagulation may be advised in all cases who require oxygen, probably regardless of the D-dimer level. If we want to broaden, and the study supports that. In critically ill patients, the current study, the COVID-backed, did show that it's going to decrease using anticoagulation is going to decrease the rate of pulmonary embolism or venous arterial thrombosis. However, there's increased rate of bleeding also. So we certainly need, if we're going to accommodate this, we need to be very selective in making sure that there is no increased risk of bleeding in those patients where we can maximize the benefit. Again, the NIH is not recommending this. This study needs to be looked at more carefully before they make the recommendation. If you allow me, Nabil, I want to answer a question that is posted in the chat about the vaccine.
Yeah, sure.
And the question is for patients who are under 20 years. It says that 1 in 500,000 die from COVID in patients 20 years or less. He says probably even fewer now with Omicron. Nearly all previously were vulnerable. Vaccine causes myocarditis in 1 to 400,000, some references 100,000. So should we not vaccinate the youngers? Well, you know, the thing is actually we're looking at individual studies, and you always find different studies showing different rates. But if we take a look here, in patients who are younger than 20 years, look at this slide here. We need to differentiate between influenza and COVID. The attack rate of COVID over time is going to be close to 100%. You know, everyone, if we say who is in this group did not get COVID yet, we all got COVID, even if we were vaccinated. Okay. So in this Canadian study, in those patients who are younger than 17 years old and got infected with COVID, were not vaccinated, 1 in 5,000 die, not 1 in 500,000. So a huge difference in terms of making decision based on data. Well, I need to verify, is that true 1 in 500,000? Because, well, most of the other studies are not showing this, showing that the rate of fatality rate is much higher. Now, look at the same group here. If we give vaccine, 2 doses, this rate 1 in 10,000, 50% less. If they get 3 doses, 1 in 44,000. Remarkable benefit of the vaccine. Okay. Now, you're telling me 1 in 40,000 they get myocarditis? Yes. If this is acceptable, look at this. This is the 44,000 here, right? They all got vaccinated. Myocarditis is majority of the cases mild. They don't die from it. Okay, here we have a patient who died out of 44,000 with vaccine compared to 1 out of 5,000. Even if you multiply this by 10, still would be worthless, worth the vaccine. And then, of course, on the other side here, look at the hospitalization rate. Look at what happened. And we just talked about the impact of overwhelming the healthcare system with those cases where we're not paying attention to the other cases.
Thank you, Mazen. Jonathan, any more questions?
I was going to say that there's been a lot of talk about the myocarditis with the vaccination, but as far as I understand, the clinical consequences of the myocarditis has been practically nothing, that they just get some evidence of myocarditis which settles after a few days. And this happens with a whole variety of different viruses.
Correct.
And it really doesn't matter that you get a bit of myocarditis as long as you make a good recovery. So the fact that the vaccine causes it in a small proportion of cases doesn't seem to be a reason to avoid it at all. But have there been reported, fatal cases of myocarditis or severely damaged, myocardium as a result, or have they behaved like other viral myocarditis, which mostly will get better?
And the other factor is, those younger ones who are infected with the virus, they affect also their parents and their elderly ones at home. Yes, he didn't die from infection, but how do you know that you did not cause? Because look at the elderly. If somebody is 80 years and higher and vaccinated, you say you give the vaccine to the elder people. Well, 1 out of 100 die, even with the vaccine, compared to 1 out of 10, of course, without the vaccine. So the general rule is actually we need to address it from all different aspects. We need to minimize the infectivity rate in the community where we don't have this virus replicated in those in those who have the most suppressed immune system, where we're going to have another variant of the vaccine in the future, of the virus in the future, where it may be more lethal.
There is a comment from Paul and Lois Goddard saying that it is 1.5 million population under 20 died from COVID 2020-2021. I just wanted to comment about myocarditis and pericarditis. I have seen about 3 or 4 cases, and they all, in fact, were self-resolved by just anti-inflammatory medications, and I haven't seen any serious cases at all. Any more questions to Professor Herawa? If not, I would like, on behalf of everyone else, to thank you very much, Mazen, for taking the time.